And without further ado, research to practice with Dominique Higgins, MD, PhD, primary brain tumors diagnosis and management strategies. All right. And our presenter, Dr. Higgins, so glad to have you here.
Great to be here. Thank you.
Thank you so much. So let's see, what do we know? We know that you're an undergraduate graduation from Stanford.
Yep.
All right, on the other side of the country. MSTP program at Mayo Clinic. Is that Rochester?
In Rochester,
All
yeah.
right. Let's see, neurosurgery residency at Columbia University. You've been all over it.
Making my way around the country, yeah.
Fellowship at the University of Miami in brain tumor surgery, and surgeon scientist at UNC conducting basic and translational research with independent funding. And then what should we know about you outside of your professional bio there?
Outside of the professional bio, I'd say, I'm a soccer dad.
All right.
A lot of my free time goes towards that, and watching the games with my two boys and taking them to practice. So
Great,
Yeah.
great, good for you. All right, well, first poll everywhere question, brain tumors that start as a growth of cells originating from within the brain are called primary brain tumors. We try to make this kind of a softball, true or false. And while you're thinking about that, I'm going to go ahead and flash up our disclosures. Don't need to read those, just need to pop those up for a minute. And let's
nice.
see how we're doing. All right, we've got responses already. What do you think? How are they doing?
This sounds pretty good. 100% true. So hopefully I have something to share then.
I'll bet you do. Primary brain tumors diagnosis and management strategies. Let me turn the clicker over to you and let you go ahead and get started.
All right. Well, thanks, Tim, for the invitation to speak today. And I think this is a great platform for not only UNC, but the broader community out there to stay up to date on some of the new advances that we have in oncology. So today I'll be talking about primary brain tumors, diagnosis and management strategies. My clinical practice is in neurosurgical oncology, so I treat brain tumors surgically, and then my lab focuses on basic and translational strategies for brain tumors as well. So we'll start with an overview of the classification of brain tumors and talk about common presentations and strategies for evaluation of patients. And then we'll move on and spend the majority of the time on treatment and clinical trial options for malignant brain tumors. The learning objectives for today, to discuss the diagnostic criteria for different brain tumors and discuss the standard treatment course for these tumors as well, and also discuss existing and upcoming clinical trials for treatment, most of which we offer here at UNC. So in terms of classification, we can group tumors by their location or the tumor of origin. So primary brain tumors, as all of you online got correct, that they start within the brain or within the adjacent brain tissue, versus metastatic tumors that start, for example, in the breast or the lung and then spread to the brain. We can classify them by compartment. On the right, we see an MRI of a tumor within the brain. Intraaxial tumors, as we call them, are below the level of the cortex or at the level of the cortex. Then within that, we can describe them as intraparenchymal within the actual brain tissue itself, or intraventricular in the spinal fluid spaces. And then outside of that, we have extraaxial tumors, or as the name suggests, are outside of the brain or below the level of the skull. And these can be within the bone themselves, or in the dura covering the brain, or in the skull base. And depending on the locations, the strategies are slightly different. So for primary intraaxial tumors, so tumors that start within the brain, gliomas are the most common, and this will focus the talk on today. But the other examples are ependymomas and, like I mentioned, intraventricular tumors. And so gliomas, they're also classified by cell of origin. So within the brain, you can have astrocytomas and oligodendrocytes, which would make oligodendrogliomas. And the WHO, the World Health Organization, grades them on a scale of 1 to 4, with 1 being benign and 4 being malignant, and 2 and 3 are on the spectrum of malignant tumors, but less aggressive. And so grade 4 astrocytoma, with some caveats, are by and large glioblastomas, which unfortunately are the most common primary malignant brain tumor. They tend to be in patients slightly older, in the 60s, compared to some of the lower grade ones, which we'll touch on. And the presentation really depends on the location. Headaches are very common. These tend to be atypical headaches different from the usual normal headaches or migraines and persists, and they may have accompanying symptoms like nausea or vomiting. Seizures are also a common presentation, and neurologic changes depending on the location. So something in the speech center will cause language changes or word finding difficulties. If it's pushing on the motor cortex or near the motor fibers, you can see weakness. And then confusion can result from either mass effect or swelling. And so as an initial workup, is a typical go-to is an MRI of the brain with and without contrast, and that gives us a level of detail to understand exactly where the cells are within the tumor and what, if it's a single location or if it's in multiple sites. In certain circumstances, if depending on the clinical exam, we may start with a CAT scan just to get a baseline assessment. And then as we get more advanced on top of that, we can add on things like tractography, which gives us a sense of where the white matter tracts or nerve fibers are running in relation to the tumor, which can help guide our surgical plan, which we'll touch on in a little bit. MR spectroscopy can give us a sense of what the molecular nature of the tumor is. If we're trying to differentiate between, for example, like a demyelinating disease and a tumor, sometimes that can give us key insights. And then PET imaging, either by PET CT or MRI, can tell us how active the tumor is metabolically, which can key us in the differential as well. So management for a glioblastoma involves, the first step is typically maximal safe resection. And the spectrum of options for these, you can do what we call a lesionectomy, where we just take out the area that's involved. Supramaximal resection has been shown to increase progression-free survival if it can be done safely. And so things in historically non-eloquent areas, we can go beyond just where the contrast enhancement is and resect what's called the flare region, where some of the edema is. We know that those areas contain microscopic tumor cells, and so we found that there's a benefit from resecting beyond just the obvious areas where there are tumors. We can do the surgery different ways. So sometimes they're in speech areas or movement areas, and we do the surgery with the patient awake. So we can test speech function to map out the areas where we can make safe corridors and preserve function. Some places do functional mapping before surgery, where you can do things like functional MRIs, so you can get a sense before you go into the OR where these areas are and then try to avoid them. For tumors that are what we call unresectable or in too eloquent of an area to get a meaningful resection without causing significant damage to function, sometimes the best option is a stereotactic biopsy, where we can put a needle into the tumor and get tissue so we can understand the molecular changes that occur within the tumor and potentially guide targeted therapy. And on top of that, at the same time, sometimes what we can do is put a laser fiber into the tumor and burn it, so we can minimally invasively get cytoreduction, which has been shown to have a survival advantage as well. And post-operatively, patients go on to fractionated radiation and concurrent temozolomide. So operative considerations, like we touched on, balancing visibility and tissue damage, asleep versus awake, different retractors to minimize pressure on the surrounding normal brain, and also to bypass or go along white matter tracts so as not to damage them. We've moved to smaller incisions and craniotomies and early recover after surgery protocols, where in some cases patients can go home the next day after the brain tumor is resected. And so this is an example of a laser ablation, laser interstitial thermal therapy. Is an image from the Visualace system that we use here at UNC, where a patient is in the MRI, and you can see that blue fiber going into the top of the head, and it's directed into the area of the tumor. And in the MRI in real time, we can turn on the laser, and using image guidance, we can see the exact areas where the tumor is being heated up, and we can protect the important parts of the brain around it using MR thermography. And then in the OR, if we're doing open resections, we've added on fluorescent guided surgery with things like fluorescein, and more recently 5-aminolevulinic acid, or 5-ALA. This is a protoporphyrin-based fluorescent marker that's specific for the glioma cells. So during the surgery, you can go beyond the areas where there's just obvious tumor and see where some of these microscopic areas of tumor cells are, and then that can help advance your resection. And in this study, we've shown that the extent of resection does matter. So keeping in mind that functional status matters afterwards, but the gist of it is the more tumor you can take out, the better the patients do long term. We have robotic-assisted surgeries in neurosurgery, and we can do that at UNC as well, and especially in the stereotactic biopsies and laser ablations, we can have high-precision accuracy below a millimeter to guide the needle and the laser fiber to the precise location we want to protect the surrounding important structures. And more recently, we can use essentially personalized tractography using AI-based software technology to map out not only where motor fibers and speech fibers are, but to get a sense of higher order cognitive functions like attention and focusing and some of these other connectomics mapping strategies that have come online in the past decade to be able to help guide our surgery, not only to ensure that the patient can speak and walk afterwards, but get as close to a normal baseline as we can as they were before surgery. Brachytherapy has also been around for a while and has gone through several rounds of evolution. And more recently, we've been using cesium-131 seeds. These are called gamma tiles. They're about 2 centimeters, and at the end of the surgery, we can implant them into the tumor cavity. And so in certain cases, we can deliver radiation immediately at the end of surgery rather than the patient having to come in for an external course. And so with all these adjuncts and tools that we have, though, median survival is about 16 months for patients on average. Prognosis heavily depends on the tumor biology. Some of the key molecular changes we look at is MGMT methylation status, which guides sensitivity to temozolomide, the main chemotherapy we use. How fast the tumor is growing, which the Ki-67 can give a sense of that growth rate. And then on average, recurrence occurs at about 9 months. Some of the landmark studies from 2005 by Stoop and colleagues, they looked at concurrent temozolomide with radiotherapy, and this set the standard of care for how we treat patients with newly diagnosed GBM. They improved the progression-free survival from about 5 months to 6.9 months, and overall survival from 12.1 to 14.6 months. And the long-term survival, so the 2-year survivals, increased from 10.4 to 26.5. In addition to that, sub-analysis looking at the MGMT promoter methylation status, which essentially gives a biomarker of how likely the tumor cell is to be sensitive to temozolomide treatment. And then what we know that the methylated tumor cells do better, and then unmethylated tumors have a worse prognosis. And so given the likely poor prognosis and not being able to move the needle much since 2005, clinical trials provide a promising avenue for increasing survival, and it's been a big push from our brain tumor team to bring these options to UNC and to our patients. So I'll highlight a couple of them that we have here, and we'll get through as many as the time allows. And we'll break them down by newly diagnosed GBM and recurrent GBM. And so for newly diagnosed GBM, one of the promising studies that we offer is this IGV-001 offered by IMVAX. The concept behind this is that you can develop a personalized immunotherapy for a patient using their own tumor cells. So after resection, the tumor cells are treated with this IMV-001 antisense oligonucleotide, which essentially sensitizes the immune system or promotes the immune system through an IGF-1 mechanism. And also the tumor antigens can be released. The tumor cells are loaded into these biodiffusion chambers, which trap the tumor cells in, but allow the antigens in the oligonucleotide to circulate and generate immune response. The antigen-presenting cells can recognize these as foreign, present them to the T cells, and then the T cells can go on to look for areas where these antigens are presented, which would be on the microscopic glioblastoma cells that are present, and then they can go on to kill the tumor cells. And so in 2001, there was a phase 1b study by Dr. Andrews and colleagues, and they looked at the safety of IGV-001 in newly diagnosed GBM patients. And to focus on the demographics for a while, there's a predominance of males, but also the patients with tumor in just one lobe wasn't the entirety of the population. The extent of resection was also heterogeneous, and then the performance status was also heterogeneous. So what they did is, they looked at the patients that received this treatment that I described, and they compared it to historical controls, the Stoop studies that, like we had alluded to before. And what they saw was that essentially patients that got this treatment did better than the historical average. But in particular, the patients that received the high dose in the bottom left had a better median survival than the historical controls at 17.1 months versus 6.5. And then when they looked at overall survival, a similar trend, when they took all comers, there was no significant difference, keeping in mind the demographics of the study. But when they matched essentially the patients that would have been eligible for the Stoop study, then they saw a significant increase in overall survival, with a median survival of about 38.2 months versus 16.2. And so this is a summary from their website, looking at the data with these, what they call Stoop eligible patients, essentially outperform the historical controls at each group. And so this led to this phase 2B multicenter study. It's randomized, double-blinded, placebo-controlled, to look at the essentially safety and efficacy of this on a larger scale. And then, given the results that they had from the 1B study, the eligibility is, newly diagnosed GBM patients, and these are patients that have not had a resection or treatment before. Patients with a needle biopsy are eligible to still enroll. The age of eligibility 18 to 70 years old, and the performance status, or the KPS as we call it, is over 70. So that kind of speaks to people that are able to care for themselves. And then exclusion criteria, listed here, having other cancers, or having other surgery before, as I mentioned, or some immunocompromised status. And so for the protocol, I'll walk through it. It can be a little complex, but when you boil it down, it's easy to digest. We screen patients that we suspect have a high-grade glioma or a glioblastoma. And then we discuss the options for surgery, obviously, with them in the clinical trial. And then at the time of resection, the patient is randomized to either the treatment arm or the placebo arm. In the treatment arm, the patients get the IGV-001 implant, and the control arm gets the placebo. And then afterwards, they go on to standard of care treatment, which is radiation therapy and temozolomide. So the real difference is this treatment with the IGV-001 in between. And so what that means exactly is, standard of care, what would happen, the tumor would be taken out, and then, after surgery, between somewhere in day 1 and 3, the patient would necessarily go home and then come back in as an outpatient for chemotherapy and radiation. But what we do for the study is the tumor is resected. For example, we do it on a Monday, and then 2 days later, the tumor comes back in these small dime-sized chambers the tumor cells have been radiated, so they can't escape or come out of the chamber. And there's also micropores that limit the tumor cells' ability to get through just by a size limitation. But they're also loaded with the antisense oligonucleotide, and then these can diffuse through the chambers so that circulating immune cells can recognize the antigens on a patient-specific tumor, and then the stimulation for the immune cells to proliferate and then go in and try to recognize where the tumor is in the brain. And then 2 days later, those chambers are taken out of the abdomen, and then the patient goes on to standard of care. And work by Jenny Silverberg, who's the chief scientific officer, published a nice study looking at the mechanism of how this works. And the thought is that it's immunogenic cell death that's mediating it. In a mouse study, they took the chambers and implanted it into the mice that then implanted murine tumors into the brain, and then tracked the growth and compared the mice that got the implant versus the control ones. And then what they saw is that, similar to the human data and with the high-dose treatments, that the mice that got the IGV-001 in the green did significantly better in terms of survival in compared to controls in the red. It was also interesting that by blocking CD8 and CD4, they could inhibit this response, which suggests that it's an immune-based therapy. And then bringing in a checkpoint inhibitor like PD-1 enhanced that response. And so we'll switch gears now to another promising avenue of treatment for patients with newly diagnosed GBM, tumor treating fields. And there's a very nice talk already on the Lineberger series going into a lot of depth with this, but I'll highlight the salient points and what are some of the updates since then. So tumor treating fields are low intensity, intermediate frequency alternating electric fields. It's delivered by a transducer array transcranially. So these electrodes sit on the scalp and deliver the electric fields through the skin. And because of that, it requires head shaving, and the goal is to wear this for about 18 hours per day for usage. The proposed mechanisms that disrupt cell division by these electric fields in the mitotic spindle gets disrupted and the cell ultimately dies. And so a study that came out from Dr. Stoop and colleagues as well looked at the tumor treating fields versus physician's choice of chemotherapy in a study they published in a large phase 3 study because they had some prior single-arm studies that showed promise, and they looked at 237 patients with recurrent glioblastoma, and they compared the tumor treating fields versus the chemotherapy of choice by the oncologist. And on the right is a picture from their paper. You can see the white cap on the patient's head is what it looks like wearing the device, and it's connected to a battery pack. And people have different ways that they can cover this up if they feel like they want to, or some people just kind of wear it out, and that's totally fine. But what they found in the study, there was no difference in survival between the patients that wore the TTF versus the patients that got chemotherapy. At first glance, this may seem like a negative study, but the glass half full version of it was that the tumor treatment fields was as effective as giving a drug, but less toxic in terms of systemic toxicity from having chemotherapy. You could avoid that. And quality of life may have been a little bit better by the metrics that they surveyed. So then this led to a follow-up study, even larger, where they compared now the tumor treating fields with temozolomide versus just temozolomide alone in a randomized clinical study. And this was started in 2009, and they published the final results in 2017 with an interim analysis in 2015 with 210 patients in that interim and ultimately 695 patients. So a very large study of patients with glioblastoma. And what they found was that the patients that had the TTF plus temozolomide did better than the patients with temozolomide alone, and progression-free survival and overall survival. Progression-free survival was about 6.7 months in the combination versus 4 months, and then an overall survival is 20.9 versus 16 months. And so this is now an approved treatment and available to patients that are interested in it. The compliance is one kind of drawback that some patients have in terms of having to shave their head and wear it 18 hours a day, but there are some patients that are committed to it and get a great benefit from it. The biggest risk that we see and that can lead to discontinuation of the treatment is scalp irritation from the electric fields. And so this led to a more recent study, which is a Trident trial, a so-called, or EF32. There's a randomized study for newly diagnosed GBM patients to now have the TTF plus temozolomide plus irradiation upfront versus doing the TTF after they receive standard of care. And we just recently closed this trial due to enrolling the targets, and then the results are pending. So we're looking forward to seeing what that yields. So switching gears now, we'll talk about recurrent glioblastoma. And one of the big promising therapies in this regard, and we're one of the, I would say, leading sites to provide this therapy, is it's called CAR T therapy. It's chimeric antigen receptor T cells. And what it boils down to, you have T cells in your body that normally protect you from infection and foreign bodies. What some clever scientists decided is we can reprogram these T cells rather than surveilling and recognizing something that they pick up through the antigen-presenting cells. We can just make them express the receptor that targets the antigen of interest, and that would be something that is on the cancer cell. So, for example, we take the blood cells from the patient by use standard blood draw, and then in the lab you can manufacture these CAR T cells where you force them to express the receptor of interest that targets your antigen of choice, and then you can reinfuse these cells back into the patient. So the goal is for the CAR T cells that are infused to now attack the tumor cells. And so work by Dr. Doty and Pelagata and Dr. Zavoldo, who lead the adoptive cell transfer program and the CAR T program here at UNC, they looked in mice and in patient samples for expression of promising targets in glioblastoma. And this top panel in F, you can see the stains for B7H3 in the GBM compared to a normal brain. And it's a pretty stark difference in terms of the comparison that it's increased expression in GBM tissue compared to normal brain. And B7H3 is a member of the B7 family, which is an immune checkpoint protein, and has been shown to be a promising tumor target. And they went on to then inject tumor cells, human tumor cells, into the mice, and also inject subsequently the CAR T cells targeting B7H3, and then image to see tumor growth, and then also track overall survival. And in the blue line, you can see the control mice that they died pretty quickly, and then the mice that received the CAR T targeting B7H3, either a CD28 or 41BB co-stimulatory receptor, they did significantly better and improved survival in vivo. And so this has led to our phase 1 study that is here at UNC to assess the safety of B7H3 CAR T therapy for recurrent GBM. The study is a safety study, but we're also doing dose escalation to see what's the maximum tolerated dose, which in cell therapy it's a bit of a misnomer. And so at the time of surgery, what we do is we need to find a way to deliver the T cells to the brain, which I'll touch on the issues with that in a minute in terms of the blood-brain barrier. In a hematologic cancer, for example, you can infuse the T cells back into the blood, and they're in the same environment as the cancer cells so they can easily find them. The brain is a privileged environment, so to speak, and essentially tries to keep out whatever it doesn't want to get in to protect it. So we have to find ways to bypass that. And for this study, what we do, we insert an Ommaya reservoir underneath the scalp, and then we can connect that to a catheter that goes into the ventricles where the spinal fluid is. So then we can infuse the T cells through that Ommaya into the spinal fluid, and then the T cells can circulate to find the tumor. And here's an example of one of those Ommaya reservoirs. They're very small and they're very flat, and they sit underneath the scalp, so you can barely feel it, but we can access it essentially like a port to deliver the treatment. And so the first step is a surgery to implant the Ommaya in the catheter. The following week, after everything's healed, then we do 3 rounds of injections of the T cells. And this is ongoing, and we're excited to be able to offer this, and we're looking forward to seeing the ultimate results, and the hope that the T cells are able to attack the tumor cells and kill them. The glioblastoma, though, it tends to have an immunosuppressive phenotype, which leads to one of the reasons why a lot of immunotherapies don't have as much success in primary brain tumors compared to other ones. So there are ongoing preclinical studies here aimed at enhancing the survival of the CAR T cells after infusion. One other aspect we want to touch on is focused ultrasound. I mentioned the blood-brain barrier penetration is an issue, that it keeps things out of the brain, so there's several strategies employed to bypass this. One we talked about is implanting a reservoir like the Ommaya to be able to allow a direct infusion. Work from Columbia, when I was over there, the group with Dr. Bruce and Cano looked at convection-enhanced delivery through a chronic implanted system that's totally implanted, so that patients can have drug delivered over the course of about a month, and they were able to show safety with that, and it was well tolerated. And so That's another promising aspect. The advantage there is you have a catheter that goes directly into the tumor cavity, so you can be able to deliver drugs at concentrations beyond what normal diffusion would allow. Intraarterial therapy is another promising avenue. There, the catheter is inserted through the groin to then deliver something by traversing all the way up to the vessels in the brain, so you can deliver locally whatever drug you're interested in into the direct circulation. And focused ultrasound is a promising non-invasive way to be able to try to address this blood-brain barrier issue. Here, what was typically employed are microbubbles are delivered intravenously, and you turn on an ultrasound, and the sonication of the bubbles, the vibration of them, essentially disrupts that barrier and then can allow the barrier to be open for a limited amount of time, and that allows local perfusion of drugs and immune cells. A graphic on the right by our team here shows that the waves coming in and then the bubbles being sonicated. High-frequency focused ultrasound is typically used for movement disorders, and my colleague Dr. Krishna has been having great success with that here. The low-frequency ultrasound, however, is the one that typically employed for blood-brain barrier penetrance and opening up, allowing for drug delivery. And their work by Paul Dayton and Phil Durham here in UNC has been pioneering that, in addition to folks like Dr. Kanafagu at Columbia. What's interesting, technology that's developed recently in a publication in 2016 by this French group by Alexandre Carpentier. They looked at an implantable focused ultrasound. You can see the device here on the right, where it has this mesh that allows it to be screwed to the rest of the skull in a low-profile way, and then you can see the different electrodes to deliver the pulse ultrasound, and also a port to activate it. And they looked at a phase 1/2 dose escalation study to look at the safety of having this implantable focused ultrasound in combination with the chemotherapy, and the drug of choice for this study was carboplatin. And what they found that the combination treatment was safe and well tolerated in the patients with recurrent glioblastoma, and this has led to a phase 3 study that's now in development and looking to be activated soon. And so we're excited to be able to offer that hopefully this year. And so, as I mentioned, there are grade 4 malignant astrocytomas, which are commonly glioblastoma, but there is a spectrum. They're grade 2 and 3 tumors that can be more benign, but also still require aggressive treatment. And more recently, in the 2021 classification in the World Health Organization, IDH mutations, or isocitrate dehydrogenase mutations, has come out as really a big differentiator in terms of prognosis for patients. IDH mutations tend to portend a more favorable prognosis, and glioblastoma is now, by definition, IDH wild-type tumor. Isocitrate dehydrogenase is an enzyme in the Krebs cycle, and mutations in this enzyme results in production of the oncometabolite 2-hydroxyglutarate, or 2-HG, rather than alpha-ketoglutarate, which is a normal product. Presentation similarly depends on location. You can have headaches, seizures, and neurologic changes, as with a glioblastoma. One of the biggest differentiators, evaluation by MRI, these tumors are often non-enhancing, so what you'll only see is the flare changes, but no uptake of gadolinium or contrast. And surgical management is similar, involving resection and with the spectrum that we talked about, either lesionectomy or supramaximal, using like awake techniques. These are not infrequently in eloquent areas of the brain, so require a specialized team that has a lot of experience with eloquent brain tumor surgery. Stereotactic biopsies used to be the standard to get a diagnosis and then potentially observe for further growth or progression. What we know now is that the upfront treatment with resection and then potentially adjuvant treatment afterwards tends to give a favorable prognosis in terms of longer survival. And postoperatively, for a grade 2 tumor, if we are able to get a gross total resection, meaning it's not involved in eloquent areas that are unresectable, sometimes we'll commonly observe for any growth before we do chemotherapy and radiation. These patients are often younger, in their 20s to 40s, and so being able to delay that has been shown to have an advantage. However, higher grade IDH mutant astrocytoma, or grade 3 or 4, will likely get chemotherapy and radiation after surgery. And a recent study in the New England Journal of Medicine looked at an IDH1/2 inhibitor to look at outcomes in low-grade glioma patients. And what they found is that using the vorasidenib, this IDH inhibitor, improved progression-free survival in the treatment group of 27.7 months compared to the placebo group of 11.1 months, which is a huge finding and potentially changing, has a potential to change the way we manage patients after surgery now. However, we need additional studies given that this was a focused group of patients, and we have to understand what the benefit is in a broader clinical context. I'll switch gears a bit and talk about some of the remaining time, talk about some of the things that are in the pipeline here at UNC that take advantage of some of these insights that we've gained. I've highlighted the role of IDH, and it shows how metabolism is critical to these tumors, in particular glioblastoma. What we see is a shift towards cellular utilization of lipids and fatty acids from both a production and consumption standpoint. And so mechanisms that target metabolism are therefore poised to be highly effective, both from a diagnostic and therapeutic standpoint. We already use PET imaging, which takes advantage of either glucose metabolism or other tracers that we use to see the activity of the tumor. In the past decade, ferroptosis was a new cell death pathway that was discovered that was shown to be effective in treatment-resistant cancers. And under the umbrella of regulated cell death, apoptosis is probably the most common one that's well known. And ferroptosis is what it boils down to, is iron-dependent lipid peroxidation. I won't get into too much detail in the schematic here. I know this is a research to practice, but I won't get into the weeds with the research aspect of things. But in a cell, you have a receptor on the surface here called system XC that essentially takes in cysteine, which you can get from diet, and pumps out glutamate, and there's circulating cysteine in the cell as well. Cell can also make cysteine from changing methionine, which is an essential amino acid, into cysteine, and this forms a substrate of glutathione, which is commonly known to have antioxidant properties. In the cell, especially in a cancer cell, it's a very hostile environment, and free radicals are constantly being formed. And then these free radicals can interact with the lipid membrane, the fat that surrounds the cell, and create what we call lipid peroxides, which are dangerous for the cell. Antioxidants clear these lipid peroxides, but in the absence of that, the cell goes on to die by a process called ferroptosis. And the cell has its built-in antioxidant enzyme, which is GPX4, or glutathione peroxidase 4, that uses glutathione to clear these free radicals, lipid peroxides. And what we've shown is that we can inhibit that enzyme, and then essentially the cancer cell is then forced to go on to die by ferroptosis, and we can use this as a mechanism to treat the tumors. And so work that I did during my postdoc at Columbia, we showed that we can use dietary means to restrict cysteine and methionine and then sensitize gliomas to ferroptosis. On the left, we have a cell model with a murine cell line. When they're treated with the GPX4 inhibitor, RSL3, we see in the red there's a dose-response curve there. But when we combine it with dietary restriction of the precursor cysteine methionine, you see the blue line is a sharp killing of all the tumor cells. On the right is a fluorescent marker, BODIPC11, which tracks lipid peroxidation, which is the reactive oxygen species that interact with the lipids in the cell. And in the middle, with the low dose of that GPX4 inhibitor, we saw an increase in the BODIPC11 signature, which suggests that reactive oxygen species are being generated. And then when we combine that with the dietary means, we see a significant increase compared to a high-dose treatment. And in vivo, when we treated the mice with diet, we saw an increase in survival in the tumor-bearing mice, and this was enhanced when we combined it with the GPX4 inhibitor. And so this has led to a phase 1 study, which we're looking to activate this year here at UNC, where we place patients with recurrent GBM on a diet that's cysteine methionine deprived in either a hyperacute or acute setting. We can use MRI and MR spectroscopy to do a molecular analysis of the tumors to see if there's any signature changes that we'll look for that match some of our preclinical data. And at the time of surgery, when I take out the tumor, we can then do a metabolomic analysis on the tissue and compare it with serum to get a sense of are we hitting our efficacy target with the dietary treatment and how long it needs to be. And the goal is to have patients with under a week of dietary treatment to maximize compliance and limit any potential toxicity. And so we're looking forward to getting this rolling and seeing if we can advance this and then use it to combine it with other therapies to provide another avenue for treatment. Another exciting offer we have is a work that comes out of the Satterley and Hinchton lab here in UNC in Lineberger. They published recently a study looking at this ex vivo platform for functionalized personalized brain cancer diagnosis using what we call an organotypic brain slice culture. It's an exciting technology where you can take rat pup brain slices, and then when we take the tumor out of the OR, we can directly place the tumor onto the brain slice, so you recreate the brain's natural environment that the tumor would see, and then you can have long survival of those tumor cells on that rat brain slice. A luciferase image here in C shows that the tumor cells are viable over at least a week's period, and then they know they can take that out even further. And then what we can then do is after the GBM is taken out of the patient, we can put it in a dish with this with the brain slice, and then we can treat it with a panel of drugs, and we can say for this particular patient's tumor, what's the most likely drug that would be effective in treating it? In addition to that, we can also assess the toxicity to the brain around it and say, okay, well, it kills the tumor, but it also affects the brain too much. And then so you can try to strike that balance in a high throughput manner to screen patients to see what's their potential for responding to existing and novel therapies. And so this is work they're actively doing now, and we have a nice pipeline and looking to continue to expand this and be able to provide a translational aspect to this technology. All right.
Okay, here we go with the questions.
Okay. So now we'll target some questions to see if there's anything that's been retained with that information. And so we'll present a couple cases and have some questions afterwards. So it's a 70-year-old male presents with headaches and confusion and difficulty reading. And MRI shows an invasive contrast-enhancing intraaxial tumor. What's the most likely diagnosis?
All right, and let's see, in the control room, you can go to a shot with both of us. It'd be great. Mm-hmm. So we'll give it about 10 more seconds. Yeah. All right, Dr.
Good.
Higgins, how are they doing?
Yeah, it's a rock star crowd today, so it's 100% right. So glioblastomas, so with the MRI, we can see that the tumor is contrast enhancing. It's intraaxial. An IDH mutant tumor is more likely to not be enhancing. Meningioma, like is an extraaxial tumor. And an arachnoid cyst is just a cystic tumor that's usually also extraaxial, but doesn't take up contrast like this. So great job. So we'll go on to the next one?
Yeah.
Okay.
Yeah.
All right. Now, 70-year-old male, same patient, undergoes surgical resection and pathology confirms glioblastoma. And what is the standard of care treatment option?
All right. We're getting some variation this time. And again, take about 10 more seconds if you would. All anonymous, so all poll
no pressure.
Always anonymous with us.
I won't take it personally. Yeah.
All right. How are they doing this time?
Doing great, yeah. So I think everyone's locked in. So yeah, temozolomide and radiation, the standard of care. The gametals, the implantable cesium radiation, not yet standard of care. There's promising data around it, but external radiation is still the standard. IMVAX is now a phase 2 study, so not standard of care yet. They're promising, and CAR-T is a phase 1 study that we're offering. So. All right. And 70-year-old male had surgery, confirmed as a glioblastoma. 9 months later now, MRI shows recurrence. What clinical trial options of these presented would be considered? This is
Good. We're getting some variety. And about 10 more seconds. Thank you all for jumping right in with the poll everywhere and all the responses. Got a great attendance today, and appreciate everyone taking their best shot at the answers on the poll questions. Good. How are they doing?
Doing pretty well. So this is a little bit of a tricky one. So we're going for CAR-T therapy, which the majority of people got right. IMVAX, or the IGV-001, is geared towards newly diagnosed GBM patients, and so it may be an option in the future, but right now that's currently what it is. Gamma tiles, it is an option for recurrent GBM, but currently not in the clinical trial form. There's a study looking at upfront treatment with gamma tiles, but not for recurrent necessarily. And then the TTF temozolomide radiation, the Trident study, was for newly diagnosed as well. So great answers and strong work. And so these are the references for the talk, and here's my contact info if anyone wants to reach out with questions, and if you want to get an overview of some of the clinical trials that are offered here at Lineberger. Here's the link, and when this is saved, it'll be an option to go over. Do we have a few more minutes?
We absolutely do.
Okay.
We have about 10 minutes.
Okay.
Let me just go to my moderation tool so that I can go ahead and promote some of those questions. As soon as I've got that up, I've got a few to get us going while we're waiting.
Okay.
So again, if you want to share questions, you should see. Oh, if I can get the clicker,
Okay,
I'll go ahead and promote to that next screw. I knew you had a few extra slides if we needed them, and I appreciate that.
Yeah.
Sometimes things wrap up early. But okay, there we go. So we will be looking for those questions. And while we're waiting, so part of what I was curious about was so many different treatment options and so many studies emerging. Talk a little bit about the decision-making process. I'm imagining you maybe with colleagues in a multidisciplinary tumor board, and you have a patient. What goes into choosing one treatment over another? What's the process behind that?
Yeah, it's a great question, and so part of what the decision tree, like you mentioned, having a multidisciplinary team that can look at things from different angles. So my view is not necessarily the same as like a radiation oncologist view and a neuro-oncologist view, but we meet every week and we present our patients and we put our heads together, and using the collective wisdom, we try to decide what are the potential options for the patient. But ultimately it boils down to that individual patient and what they and their family are interested in doing and what they feel is right for themselves, and then we try to make a decision together. We also see the patients in a multidisciplinary clinic as well. So one, it's convenient, so they don't have to kind of travel around, but we can also have a real-time discussion amongst ourselves with that patient feedback to try to decide on what's available. And then on top of that, what's important is that we're not in our own bubble here at UNC, and so we have these networks of brain tumor groups that collaborate, and so there's in addition to the interdisciplinary wisdom in the institution, we talk around amongst ourselves around the country to share, well, if we don't offer something, we know something that may be more in line with what's best for that patient at another place, and try to connect them with the team there. So try to think of the the bigger picture and then just ultimately try to do what's best for the patient.
Great, thank you. And I'll both put in a shameless plug for an earlier lecture and then ask a question at the same time. So back in April, we had Dr. Who from Cedars-Sinai talking about ketogenic diet.
I remember I watched that one.
Good. And treatment of glioblastomas. I know you mentioned dietary treatment, and I was interested in knowing a little bit more about that, as well as what that dietary treatment entails. And then, are you seeing any discussion of the ketogenic diet?
Yeah. So it's something that comes up pretty frequently, and the common questions I get, why did this happen, and also, what do I eat? Is a common question, and we don't have a perfect answer, and part of it I say, a lot of what's there for dietary treatments is experimental. So, you have to do something that you don't want to stick to a diet that makes you unhappy because your quality of life is affected. And so part of it is taking that into account. The ketogenic diet focuses mostly on addressing carbohydrates. And the strategy there it tends to be maintaining it over a long period of time to keep the body in ketosis. And that's been shown to have some efficacy in terms of limiting tumor growth and also sensitizing to things like radiation. It kind of spun out of work in the epilepsy field where they found a pretty a significant decrease in seizure frequency in certain epilepsy conditions. And so I don't personally work on that, but our take is a little different. So ferroptosis tends to be more of a low protein diet rather than targeting carbohydrates, and we have some additional tweaks on top of that to try to enhance the effect. What we're also shooting for is not to maintain anyone on the diet for the rest of their life, but rather to use it as a synergy with other treatments that we know can combine with the diet to enhance the effect in an acute treatment period. So that's what we're shooting for, and we have some promising data in the lab in terms of work we're doing on recurrent GBM as well that hopefully should be coming out in the near future, and excited to see where this goes.
Great. Well, thank you.
Yeah.
Access to the slides. Somebody says, great presentation, asks about the slides.
Thanks.
Those are available on the Learning Portal. And then if you have any trouble accessing those, just please go ahead and contact our team, and we'll make sure that we can show you where those are. But you should find those on our learn.unclcn.org. What are your thoughts on poliovirus treatment for GBM?
That's not my particular area of expertise, but it's been popular in the media and in scientific circles, and there are groups that are working on that. The initial studies I think didn't show the efficacy that they were hoping for on a broader scale, but I know there's some efforts to readdress it and potentially re-examine that from a different angle. So we're waiting to see what the results that come out of that. I'm a fan of trying to use viruses to treat tumors in whatever capacity you can. There's different vectors that people use. It's not necessarily something specific about the polio virus. There's adenoviral treatments, and DC-Vax was something that recently the results of that came out of, and Matt Ewan, who was one of my partners in neurosurgery here, was a part of that study. So they are all promising. It just depends on what your target is and how you deliver it. The good thing about viral-based treatments is that like I mentioned, glioblastoma is a very diffuse process. So having something that can kind of seek out tumor cells in a microscopic way, I think will always have some promise. So.
Thank you. And thanks for that question. Another one, what is the standard initial treatment for diffuse astrocytoma grade 2 IDH wild type?
So if you can do a resection, that tends to be our go-to initially. If imaging-wise we're convinced that it is an IDH grade 2 wild grade 2 IDH wild type. Yeah. Resection would still be the initial treatment. We'll have to get a sense of other molecular markers that are there to decide if we're going on to do any adjuvant treatment. If it's in an area that's not resectable, for example, we have these H3K27M tumors that sometimes can be in the pons. Those are not resectable, and so we tend to do just biopsies for those. But there are targeted treatments for those, like HDAC inhibitors that are also experimental, that also show promise. Histone deacetylase inhibitors, that can be potentially useful, and have had some success with that preclinically in some early clinical trials. So it just kind of depends on what comes after either the biopsy or resection, if possible.
Thank you. For increasing median survival of GBM, is focus on novel treatment options for primary GBM patients, or rather recurrent GBM, considering studies elucidate that near total resection can be reliably achieved in a reproducible manner?
Is a focus on novel treatment for primary. So I'll jump on my soapbox for a little bit. I think that for a patient with a newly diagnosed GBM, we should try to do as much as we can upfront to try to see what's the best chance we can to treat this, and that's one of the reasons that I'm personally excited about the IGV-001 study. There's not a ton of trials out there for newly diagnosed GBM patients, and so one of the projects in my lab is what happens after the tumor recurs. You think about the process. You do surgery, you do radiation, you do chemotherapy. Now the tumor that grows back is essentially resistant to a lot of these things that we subjected it to. So I think studies that focus on strictly recurrent GBM, there's value in it in terms of valuing safety, but when we really target efficacy, I think it's important to understand what are the changes that happen in the tumor, and is that context still matching any preclinical data that we have. And so what my lab is working on is essentially developing a recurrent GBM model in mice so that we can be able to screen the pre-treatment and post-treatment environment and say, okay, well, if you have a drug that you tested in a newly diagnosed GBM, is it likely to be effective in a recurrent GBM as well?
Gotcha.
And I think that understanding that context is important in terms of designing your clinical trial ultimately.
Gotcha. Thank you. And thanks for all the questions. Okay, one last question.
Okay.
Can I see that little reservoir for a minute? I've been dying to see. So that's got some sort of a self-sealing mechanism there, so you can inject and then put pressure on there, and then that.
It's not been in a patient, so it's clean. You can hold it.
Okay, but the notion is you can inject this multiple times, self-seals.
Yep, exactly.
Then you just put pressure on that, and that moves the.
Actually, it just flows in by diffusion.
Yeah,
this will be connected to a catheter that goes down into the brain, into the ventricle. So whatever you put in this reservoir kind of flows out into the brain.
Okay, great.
Yeah.
I'm always asking presenters to bring in props, and I'm so glad that you did.
Yeah.
It's really interesting to see what's behind some of the work that's being done. All right. Thank you all for these great questions. We want to thank, as always, the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, the UNC Lineberger Cancer Network team, that's Veni Obore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, Lindsay Reich, and Barbara Walsh. Each of them plays a part in making all of this happen, so we really appreciate that.